7:30, all right. Well, welcome. I understand with the rain that we could have a little lower attendance in person, but if you're in the building over here at Tanglewood, come join us. Dr. Permeshwar is out a little bit this morning, so you're stuck with me doing the introduction, but we've got Dr. Mohamed Nagiub with us for doing, obviously, advanced cardiac imaging, which is on the flyer and on the screen for those in here. Mo graduated from Alexandria Medical School, and then he completed residency in Michigan at the Detroit Medical Center. He wrote this intro, so I'm going to have to expound on it a smidgen. He then went to VCU for pediatric cardiology, as well, and he says as well as University of Texas Southwest for children's in Dallas for pediatric cardiology advanced imaging fellowship, which we're going to learn a little bit more about today. And he became a member of UK's United Kingdom's Royal College of Pediatrics and Child Health. Now, the story on his fellowship on advanced cardiac imaging, we had this great cardiology fellow that graduated, and we recruited him. And then he told us, well, just kidding, I want to go do this. So he went away for a year, and we were just tickled to death that he did come back, because this is a pretty advanced skill. There is cardiac imaging going on. We got a couple of the radiology folks in here today. They can tell us that in the adult world, but as with everything, we always say pediatrics is not little adult. And so, but Mo has been doing a beautiful job working with both radiology department with anesthesia to get the sedation worked out. He's really paving new ground. So the CT folks, within radiology, it's just. So we're tickled that you got this going and are meeting a need that's pretty unique.
Thank you. All right. Thanks, Dr. Thanks, Dr. Pierce, for this introduction.
But if you want to unmute it, hold on. Do you want me to unmute it for you? It should work.
Thanks, Dr. Pierce, for the introduction. I appreciate it. And thank you for the invitation for today. So I'm happy to present actually my passion, advanced cardiac imaging. Well, I have to say, no financial disclosure. So the objective for our lecture today is define what are the advanced pediatric cardiac imaging, advantage and disadvantage of each one. We will talk about each modality. Identify proper utilization criteria for advanced cardiac imaging. We will just share with you a lot of beautiful images, but it's also very diagnostic. It really helps not only for cardiology, although I'm saying it is pediatric cardiology imaging, but it's also helpful for other pediatric, general pediatric, as well as pediatric subspecialty. And finally, just to, as educational, for educational purpose, stipulate different pediatric cardiac imaging orders. What are the orders? Because sometimes the resident doesn't know what exactly to order and how each one could be helpful. So when I say the advanced cardiac imaging, I will talk today specifically about the MRI and the CT. So I will start with the MRI, saying what are the indications? When shall I order a cardiac MRI? So first one, we definitely have a lot of studies of transthoracic echo in our cardiology practice. But if the transthoracic echo cannot provide the required diagnostic information, that's an indication for cardiac MRI. If there is a contradiction between the diagnostic test and clinical assessment, so something it doesn't get along, that's also an indication. As an alternative to diagnostic cardiac cath with its associated risk and high cost, so definitely the cardiac MRI is cheaper than any cardiac cath referral. And then to obtain diagnostic information of which CMR offers unique advantage. So things that MRI can offer, none other diagnostic modality can offer. I know the CTs start to do the same, but we still, technical-wise, is not there yet, which is include tissue characterization and flow quantification. And I will go through this. What does it mean? I'm just sharing with you, this is a Boston Children's Hospital talking about the volume of the different diagnoses for cardiac MRI. And we can see here, we have,
Wonder doesn't work on the screen.
sorry. We have different diagnoses. We have 20% tetralogy fellow, 15% aortic coarctation, 14% complex two ventricle or transposition, single ventricle 10%, septal defect, anomalous of pulmonary veins, some cardiomyopathies, vascular anomalies, Kawasaki disease, congenital coronary anomaly, cardiac tumors and cardiac mass and cardiac thrombi, which now we start to see much more frequent, or we start using CT and MRI much more frequent. We have at least 4 or 5 patients in the PICU, inpatient, which are required to do extra imaging for that, and others which I will include in our discussion today. So the advantage of cardiac MRI, it is tissue characterization, as I mentioned, like myocarditis, tumor, iron overload, sarcoidosis. Echo cannot diagnose any of that. CT cannot, because this is very unique for cardiac MRI. Definitely, CMR have a higher resolution than echocardiography, so I can better see coronaries if I'm unable to see it in the echo. Pulmonary veins also have MRI is diagnostic. Some small structure, like something we do in single ventricle, the first stage of single ventricle, something called DKS shunt. Extracardiac structures, usually I always explain this to the parent, saying echo, it is echocardiography. It shows mainly the cardiac structure, what is beyond the heart. Usually the other cross-sectional studies, either cardiac MRI or cardiac CT, have a better diagnostic power. So we're talking about vascular ring, coarctation, bidirectional gland, Fontaine shunt, which is the last two, is just the 2 steps for single ventricle surgeries. Then MRI also is capable to do something called the flow quantification. And the flow quantification, we always hear about the VSD or ASD. This is the simple way of flow quantification. They say, oh, it is hemodynamically significant VSD or hemodynamically significant ASD. MRI is capable to tell how much perfusion is going to both lungs and each lung, how much it is, which is something very unique for MRI. And CT is still unable to reach this, but it is in the process for that. Disadvantage, definitely sedation, because this study usually takes about an hour to do the basic cross-sectional localization and then get the function. So from 1 to 8-year-old, usually the sedation is our best friend. The study duration, as I mentioned, is around 60 minutes. Metallic artifacts, sometimes it can make the MRI really difficult, like pacemaker, ICD, if there is an orthopedic. But now there are more and more devices coming out, which what we call it conditioned, which has MRI-friendly devices, so that we can use it and it does not affect the MRI. Scheduling the restriction, mainly for outpatient, that's sometimes also limiting us. But usually for inpatient, we usually will be able to schedule those patients much easier. For cardiac CT, definitely cardiac CT have the highest resolution and even better than cardiac MRI. So if a structure I'm unable to see in MRI, CT have higher resolution than MRI. The best thing is, we're talking about second of a procedure. So patient is in, 2 seconds, already the study is done. And no sedation for most of the patients. Unfortunately, if a patient is developmentally delayed or have any psychological trauma, especially like have been admitted to the hospital multiple times, have been get a lot of IV lines, recently get some PIC line, usually we see those are the most difficult patients to deal with. Better resolution for extracardiac structure. So usually cardiac CT can get for us better 3D volume, and I will share with you a lot of studies which we did. Disadvantage of cardiac CT, always they say, oh, it's radiation. But you can see here, the table on the left, that nowadays everything is actually pediatric adapted. So back in the days when we used to talk about how the radiation is bad for kids and how it affects, nowadays it's actually, weight and BMI adapted radiation dose. And actually the newer scanner, we use the Force, have the highest software that it's actually specifically for pediatric. It can modulate the dose which we are giving to the kids, and we give almost like as if it is 2 chest X-ray exposure. Duration-wise, you can see in the one in the table on the right side, and you can see the scanner which we are using in Force. We're talking about 0.24 seconds. That's the actual duration of exposure. And in comparison to the other modalities, definitely there is a big difference. How much, like 0.2 seconds, the cardiac CT is already done, and we get all the structure we need. We later on, we get all the process, later on, it is all being processed by the machine as well as by the technicians. They usually do the adjustment, choose which cycle, which part of the cardiac cycle need to be processed, and we do the calculation from. The second disadvantage, which is sometimes also being brought, is the iodine that we give. This is iodinated contrast. So there is, if there is someone from endocrinology, they know that iodine-induced hypothyroidism, it is a well-known phenomenon. It's called Wolff-Chaikoff effect, and it is a physiological response for supraphysiological iodine for 2 weeks. So it causes some suppression for 2 weeks, and it could persist only in preterm or sick infants. So according to the guidelines, that a screening TSH is suggested, and this was recently published in May 2022, after 2 weeks to check the TSH and making sure that the TSH is coming back to above 10 micromole per liter. And we already started this, I think, 2 months now, or?
Even longer in the FDA.
Okay, yeah. So I will start showing some examples of advanced cardiac imaging, cardiac lesions. So we use this advanced cardiac imaging for established diagnosis, preoperative evaluation, and postoperative evaluation. Going back through what are the publication and guidelines of advanced cardiac imaging. So the first guidelines published multimodality imaging, including the cardiac CT and MRI, was published in 2014. And talking about how the cardiac MRI and the cardiac CT is very helpful. And this was published in 2014, as I mentioned, and showing different examples. You can see here in this image, this some branch pulmonary stenosis, and it's very specific at which age, what to do, how frequent, and what are the advantages for cardiac MRI versus a CT versus lung perfusion scan for those patients for tetralogy fellow. I will not go into the details because it's more cardiac. Then the second also guidelines have been published in 2016, talking about transposition of great vessels and also the role of multimodality imaging on those patients. And you can see here a lot of pathology. I'd like to, I don't know if I can use the mouse. Yeah, it is. Okay, perfect. So you can see here, this is like coronaries. It's showing in transposition, one of the more common associated lesions is coronary anomalies. And it shows here different coronary structure, which definitely echo cannot show us any of that. especially a lot of transposition have been already operated. Sometimes they have a pericardial patch. So the resolution for transthoracic echo sometimes is very, very difficult for postoperative patients. And here, you can see here the LAD is, left anterior descending artery is anterior to the right ventricular outflow. So sometimes that's something I need to tell the surgeon whenever you like to approach the right ventricular flow or you like to operate, you are very close to external wires. When you open, make sure that the left anterior descending is in your way and it's very close. It's a few millimeters away from the bone. So if I don't, in the multimodality imaging, if I don't recognize something like this, and the surgeon just put this like this, so here, first thing you will hit with the left anterior descending, which is the main coronary for the heart. Again, here, something is very common, known for arterial switch, this positioning. You can see here the main pulmonary artery, the right pulmonary artery, left pulmonary artery, and you can see the aorta in the middle. And this is, Draft sign is very common thing that we find in transposition of great vessels, because whenever they switch, this is the typical position post the arterial switch. And sometimes some narrowing can happen in the branches, and you can see here where the arrow is showing, it's like really, really tight. And instead of doing a cath, very common also that with the transthoracic echo, we cannot see that. And the reason for that, sometimes this here have a stent, or on the other side is have a stent, so that the stent shadow overlap the echo, the pulmonary artery branches, and the multimodality imaging, like a CT or MRI, will be the best, our best different for that, to show actually how the branches looks like, how the coronaries looks like, and we give actually also an accurate measurements, which have been validated in multiple studies with the cath and with the surgeons. So whenever we measure, we measure something called the double orthogonal measurements, which we make sure we are totally perpendicular in the vessel. We get an accurate measurement, and we put it in what we usually say is Z-score, which is according to the body surface area for the child. So I can tell the cath person, I can tell the surgeon, this is hypoplastic, and the Z-score is this number. So it's better to say, I can operate on this patient, or I can stent to this patient. Thanks, Dr. Gay, for attending.
I felt bad for being late. I'm sorry.
No. Third is single ventricle. Also, this have been published guidelines for appropriate use criteria for multimodality imaging follow-up care for congenital heart disease. This was published 2020, and it go lesion by lesion, including the single ventricle, when to use transthoracic echo, when use the cardiac MRI and CT, and you can see here the green, it's favorable, the yellow is moderate, and the red is avoid. And you can see this is, it's something very important, have been totally incorporated in all congenital heart disease management and treatment. So now all the centers, this is the standard of care. They do the studies, and even sometimes they don't need to do a lot of cath. So back in the days before they do the Fontaine surgery, they used to do cath for every patient. Now, many centers, what they do is just to do an MRI. The MRI is capable to show every structure that the surgeon will handle during the Fontaine completion, as well as it will show the flow quantification. If any collaterals need to be closed, the MRI will be capable to show the collateral and to quantify how much burden on the heart. So when we do the MRI, we say, let's say 1 liter per minute per square meter, which is about 12% of the cardiac output, which is tell the surgeon this is a hemodynamically significant collateral, need to be taken down, versus it is insignificant collateral, it will not affect the child in the long term. We talk about how the MRI could be helpful. So here I'm just showing, that's a simple example. This is what we call a single ventricle, and you can see here the right ventricle is the dominant, the left ventricle is hypoplastic. And what is a power of cardiac MRI, it can calculate the volume without using the usual echo mathematical assumption. So we usually use something called the disk method in LV quantification. But this cannot be done on RV because RV is not conical the same way as the LV. So the only way to actually measure how much is the volume for the RV and how much the function of the RV, it is only by MRI. CT also can do the same, but the CT, you have to do the retrospective, which is the full cycle. So I do the during systole and diastole and do the calculation. Something else also, now the MRI being used to, let's say I have a big ventricle and the other ventricle is small. We go in this debate with the surgeon and with the cath people, is it how small it is too small to do a single ventricle repair or two ventricular repair? This is the MRI as well rule. So we usually calculate something called left ventricular endostolic volume, and it is indexed, and there is a cutoff values that I can tell the surgeon, this is a good volume that possibly this patient will go through the biventricular repair rather than univentricular repair. Again, echo cannot make this decision because again, most of the echo which we use, we assume that the ventricle is conical, disc shape, but whenever it is hypoplastic or whatever, or whenever it is a right ventricle, this is very difficult to be done by echo, or almost impossible to be done by echo. And as I see, I shared this study with you. It is the comparison of echo and cardiac MRI for functional sync ventricular volume. And you saw and this have been done by Pediatric Heart Network. So they are comparing both the echoes and the MRI, see how valid it is. So this is, as you see, this is 2009. So those questions have been answered a while ago. And all the studies now, all the centers are using MRI and CT to answer these questions. Other congenital heart disease, it can be used in ASD, VSD, vascular rings, double outlet right ventricle, Stein, pulmonary atresia. I will just show pictures. I will not go into details because it's too much information. But we talked for a while about what's called the flow quantification. What is meant? This is something with the MRI also can do. And there are two types of flow quantification. There's a 2D and 3D flow quantification. And you can see here the flow quantification, which can be measured by MRI. It could be intracardiac shunt, or it could be an extracardiac shunt. The MRI is capable to measure both. So if we're talking about ASD, VSD, the MRI can measure that. If we're talking about aortopulmonary collateral, the MRI can do that, which is sometimes it is not easy and less and more expensive to do that with the cath. I'm just showing some lesions. So you can see here, this is a double arch. And you can see each arch there are some vessels, so the right lesions coming from a right arch, and the left vessels are coming from a left arch. This is a pulmonary sling case. This is a circumflex arch, and this is a patient of this is an NICU patient. So this an NICU patient referred to UVA, and they operate this patient. It's a vascular ring. Initially, by the echo showed possible coarctation, but it was atypical. So we were not sure. So we did the CT, and the CT showed a beautiful picture of what's called left circumflex arch, and we referred to UVA, and this patient was operated. This patient also have multiple other congenital anomalies. So it was very interesting and very rare case. Just showing also more pictures about double outlet right ventricle. So MRI and CT can be very helpful for surgical planning, 3D printing. So I work in UT Southwest, so what they used to do for double outlet right ventricle is they do the study, and then they print. We do 3D printing for the model. We print it as a rubber, and the surgeon approach this rubber model to see where's the baffle, which is the patch. We're closing the VSD, will run across, and if this is affecting the outflow or the inflow of the heart. So it's something now that they use. Some of the 3D printer lab reached to me. We will trying to start doing 3D printing for some of the cases. Hopefully this will happen soon, and still, as far as I get from the feedback from them, that they're still using the plastic material, not the rubber one, but it would be something very, very helpful, and we discussed this with Dr. Priest, that this is something can be done also for medical students, because whenever you talk to the medical student, tell the medical student there are different type of VSDs, or there is different type of ASD, or there is different type of AVSD. Atrioventricular septal defect. What about you see the AVSD, and you see the ASD, and you see the AVSD? So what we do is we can print that, and I make a window in the atria, and this can be done just by the software, and make a window in the ventricle, so the student can look at the ASD, can look at the VSD, or even I can sagittally or cross-sectionally get the heart, and the student can look, or the resident, they can look inside and see exactly what we are talking about in 3D model. Also, for Stein anomaly, MRI can assess the severity, how much of the right ventricle have been atrialized, and according the severity of this, I'm just showing a picture how we do this assessment, like in drawing, but according the severity, it make the decision for the surgeon much easier. Like, is it mild? Is it so we can save the tricuspid valve and save the right ventricle, or so severe we treat it as if it is a pulmonary atresia and we cannot save that. So it is. There are scoring index, 3 different scoring index, and according to this, the severity, there will be the management plan. We talk about pulmonary atresia with VSD. So the CT, you can see here showing the direct aortopulmonary collaterals coming out. So the in pulmonary atresia, there is no right and left pulmonary arteries. So most of the time, what they have a direct collateral coming out from a descending aorta to supply the lungs. And again, echo cannot show that, but the MRI can show exactly. You can see here the descending aorta, and you can see each branch. This is going to the right upper. This is going to the right middle and right lower, and those are going to the left upper and left lower. Something like this, it cannot be shown by echo with this resolution in this picture. So that's just very helpful, because again the surgeon will decide, or we'll do something called unificalization, which is we'll keep the bigger vessels and try to put the vessels all together and try to connect it to the pulmonary artery if a part of the pulmonary artery is still there. Again, one of also problems with us in the echo is pulmonary atresia without VSD, that sometimes they have something called the ventricular-coronary sinusoids, which is that the coronary is connected to the hypoplastic ventricle through the sinusoids. And there are different types. And again, you can see that the CT, because of the highest resolution, it shows where is the sinusoids located and where it is connected to each coronary. And that's also make the decision for the surgeon much easier, because the presence of sinusoids means that this patient most probably will not go through biventricular repair, it will go to a univentricular repair, but also some of those sinusoids can be blocked if it has certain criteria and they can save the ventricle. I'd like to, for congenital coronary anomalies, I'd like to share with you this case. It is also done here. So this is a single coronary artery origin. So we can see coming out from the right coronary sinusoid, a single vessel that divide and give RCA and LCA. And the dangerous part of those kids, the left coronary artery, it has to go where the left ventricle is located and to supply the left ventricle. But the difficulty, it sometimes pass through the myocardium. So whenever those adolescents are active, those are the cases which can have sudden cardiac death. So this case it presented with Marfan, and there was an old history that this case have anomalous coronary. Mom doesn't know what exactly is going on. So echo is unable to show this. We did a CT for this patient, and it showed intramyocardial course of the left anterior descending. So I restricted the child totally from any activities. And parents were not happy. The kid was athletic and playing a lot of games, a lot of sport. And I discussed this with UVA, and they say, if you guys have the capability to do a stress cardiac MRI, we like to do it. So this was our first cardiac MRI at Carilion. This was done in April. Even adults, they don't do any stress cardiac MRI. So we were able to do the stress MRI using dobutamine. So this is the same patient, and I'm just showing you. So that's at a dobutamine 20 mic. So we give, we escalate the dobutamine on those cases from 10, then 20, then 30 mic per kg, observing all the vitals for those kids. And then also, if we didn't reach to the maximum heart rate, we give atropine. Once we reach to the maximum heart rate, means that this is the maximum exercise capacity for the child. And if the child doesn't have symptoms, doesn't have any abnormal contractility, that's a sign that he passed the test. So we discuss this, we review the guidelines, and we allow him to be back to sport, but we will follow every 3 years, do the same test according to the guidelines. So we give him the capability to be able to exercise, since our stress cardiac MRI with the maximum heart rate achieved is normal. That's exactly what he would be able to do. But we are following every 3 to 5 years because we don't know if there is some atherosclerotic processes start to develop, some narrowing start to develop to reach to the critical level that it will affect his myocardium, or will start some type of arrhythmia, or will have a symptom. So we will try to be doing this every 3 to 5 years and making sure the child follow up regularly. And if he has any symptoms, he has to let us know. So that's yeah, Dr. Gay.
I don't understand. So in that case, the left, which one was coming from which one?
So
left from the right.
Left main coronary artery is coming from the right.
So it didn't go posterior.
Yeah.
It went anterior, but yet there was an intramural course.
Yes.
So there wasn't any concern about the location. It was the intramural course.
Yes. No, it is intramural course as well as intramyocardial course, because it go a little bit inferior, going through the ventricular septum.
So, yeah, I understand.
Yeah.
So I'm just trying to learn something. If that was a problem, is there anything you can do about it surgically or whatever? Or put a stent in it, or I don't know.
Surgically, what they do is they do unroofing for this coronary. But the problem with unroofing for those coronaries, this kid also have a Marfan syndrome. So the original diagnosis for this kid, for the referral, is Marfan syndrome, genetically diagnosed.
But he didn't have.
By the way, but it doesn't have any ascending aorta dilatation. It doesn't have.
So it's okay.
But a genetic diagnosis in, I think, in Wisconsin. And by the way, one of the echoes mentioned some anomaly of the coronary. Mom and dad didn't follow up regularly. And it's like, oh, everything is fine. We just moved here like last year, and just making sure everything is fine.
So he was presented because of his genetic diagnosis, not for any particular symptoms?
He doesn't have any symptoms. He's just doing regular checkup, although it is not regular, it's 3 years or 5 years from last time, for a Marfan syndrome. And then, by the way, when we requested notes, actually the notes show, like previous echo showed anomaly of coronaries, but it was never been any details more than this.
But that should have been done, though.
Yeah.
Because if you see a left coronary from the right coronary, that's a red flag.
So I'm assuming that this technique may be helpful for other youth who have symptomatic exercise symptoms where you're worrying about
Exactly right. Exactly right.
position.
Yeah.
Dr. Nagiub, the stress testing MRI, is that something that we're doing?
Yes, we did.
I know we did it.
Uh-huh.
Is that something that's going to be offered going forward?
Yes.
It sounds like you're doing the same protocol that nuclear medicine uses dobutamine for, very similar. And I'm guessing this is a younger person, so the heart rate target is going to be very high. Now, most of the dobutamine studies, if I understand, are done on older men. Is that
It is the same. It's like the maximum heart rate usually we calculate it, even whenever we do treadmill, exercise treadmill, which we do in the clinic. It's a fixed calculation. Usually we are looking for 18-year-old kid, less than 18-year-old, a pediatric range. We're talking about 178, 180 beats per minute. That's the maximum heart rate that the kid can reach.
So I guess he had no STT changes or anything on regular exercise tests.
Initially I did a regular exercise treadmill test. It was negative, and then they said like for validation. And actually there is a beautiful study done by Texas Houston Children's Hospital, Texas Children's Hospital, and they did on 250 case, and they have amazing algorithm according the lesion, what best, how long to follow. So it is supposed to be actually like our guidelines. There is no published pediatric guidelines for coronary, but this is the main paper for those anomalies of coronary vessels.
So what you're looking for is a change in the ventricular contractility?
Yes.
Okay.
So usually I'm expecting to see a change in segmental change corresponding to the coronary, which I'm thinking it will be impaired. So if those segments have been show any abnormality, that will be positive. In addition, if the patient have symptom, in addition, if it show any type of arrhythmia.
Which you can actually see a narrowing though, right?
Yes.
As well as some segmental thing, because if
actually,
there's some
we did-
segmental thing, I would think
So
the
this
resting,
This is also something I'm looking forward to do is, unfortunately, the software which we are using currently for cardiac MRI, I used to use better software which can do something called the strain analysis. So we used to do strain analysis in segment-wise. So at each dose, we do strain analysis, and we can tell if any of the cardiac segments have any abnormal strain abnormality or any strain changes. And once we do this, it's not only objective, not only subjective, which I'm seeing if any abnormal motion, it will be in numbers. It will be an objective telling me the strain analysis at 10 mic versus 20 mic versus 30 mic versus 40 mic. That will be really, really helpful. So we are looking forward to get this software, hopefully. Something also I find that I introduced this in Society of Cardiac MRI. It's talking about post atrial switch. This is the old form for transposition of great vessels. And it was an interesting case, so I'd like to share with you the images, seeing how much this can be really helpful. So this is a case, unfortunately it's not moving. So this is a 3D model. So after we do the cardiac MRI, what we did is we process it in the software and this is the printout for the MRI. It's supposed to be moving 360 degrees, so I show you the structure. But you can see here the SVC, you can see here the IVC, and it's supposed to be on those atrial switch that they connect to the systemic venous flow coming from SVC and IVC and directed into one ventricle, and then the pulmonary veins go to the other ventricle. So they do what's called the atrial switch for cases of transposition. And for cases like this, definitely echo cannot make any diagnostic. If there is, it can be, but it is very, very, very difficult. You have to use a bubble study and see how the venous return is coming. But if you do a cardiac MRI and a cardiac CT, you can definitely see exactly where the narrowing is. Let me show you where the narrowing. So here is the area where the narrowing, so this is the SVC, and you can see here's the narrowing happening. This is the IVC, and it's all running behind the atrium. And this was supposed to be the pulmonary veins. Coming to this, we open section in the atrium to show this, the pulmonary veins going into the atrium, and this is directed into the other ventricle, which is the left ventricle. So this is a case, is not a pediatric case. This was a 45-year-old post-atrial switch patient, and this patient had an atrial fibrillation, and electrophysiology people was unable to access any of his main vessels, because if they go from the SVC, they have no access because of this narrowing. The catheter cannot be introduced. If they go, I will show you from the IVC, if you have like a femoral access or inguinal access, it also, they are unable to do it. So we did this MRI, and actually, this is also the inguinal area. You can see here, all because of the narrowing here in the veins, it's all collateralization of the vessels all through, and there is no way any catheter can go through all that. So when we did this study, we found that the hepatic veins have a direct access to the IVC, and so what they finally did, they did a transhepatic access to the through the hepatic vein, go to the IVC, did the ablation for the patient, and everything is fine. So case like this, you can see like how much it is helpful for the cath people and for interventionists for planning for the next management plan. Then I will go we've been talking about cardiology, so I will go through some other specialty. Is it helpful? So I see here a rule of advanced cardiac imaging in pediatric GI. If a patient presenting with a feeding problem or failure to thrive, one of the things that you should rule out that if the patient have any vascular ring, why this is happening. And you can see here, this is a double vascular, double aortic arch, and you see LCCA This is left common carotid, left subclavian, right common carotid, right subclavian. And you can see that those are the two vascular rings surrounding the trachea and surrounding the esophagus. This is another case. You can see this is the verticulum of Gomerel, and the left subclavian is coming out, and it's totally total closure to the surrounding the trachea and as well as the esophagus. Back in the days, he used to do barium swallow to show the indentation, and according to the location of indentation, they suggest what type of lesion is there. But now we have more diagnostic capability that we can actually see rather than we see just the indentation. Pulmonology is here. So rule of advanced cardiac imaging for pediatric pulmonary pulmonology or ENT, if a patient presenting with breathing difficulty. This is supposed to be a video, but unfortunately, because we changed it, the videos says it show like they are getting through the bronchoscopy, and this is a pulsating lesion. So we used to get a lot of referral for bronchoscopy, pulsating lesion. And guess what? We do CT and we show that how close the vascular ring to the trachea, and that's the reason of pulsation. But also here we can see how in 3D how the vascular structure can be compressing the trachea, the lower part of the trachea. Something also being described in literature, inspiratory defect in pulmonary function test. We can see this indentation in inspiratory flow volume. It means that something going on when in inspiration. As far as I remember from a pediatric, it could be vocal cord dysfunction or vascular ring. Those the most common to inspiratory. Correct me if I'm wrong. Pediatric infectious disease, myocarditis, definitely very big rule in cardiac MRI, because again it shows the tissue characterization. It can show also if there is edema. You can see here we do a late gadolinium enhancement, and we can see here the lesion. And it is not only late gadolinium enhancement which we should look for, but we do another studies which called T1 and T2, and we can tell if there is edema and if there is an extra fluid, calculating something called extracellular volume, ECV. And you see here a signal which coincides with the signal here, which is making sure that we are, this is a true lesion. Nothing is just an artifact or anything like that. Endocarditis, and I was lucky I was able to publish this value of time resolved cardiac CT in congenital heart disease and the infective endocarditis, published in Pediatric Cardiology this year. And it shows how the CT can be helpful to show structures that sometimes, and we compare this to the transthoracic echo, how the transthoracic echo, sometimes it can miss smaller vegetations, or it can identify the vegetations in a better way by the CT than the MRI. In addition, if you have the right software, what you can do is you can actually see if there is perforation of the valves. So this patient have a perforation of valve. We do something called endovascular processing for the cardiac CT, and you can see those two arrows showing the holes in the valve, and we can tell exactly the surgeon those holes or this valve need to be repaired. Talking about pediatric infectious disease, Kawasaki, very common diagnosis. By CT, I can see the whole coronary artery, and you can see here the whole coronary artery is visualized. I can tell exactly how many aneurysm, how many ectasia, if there is any atheromatous Blake going on this lesion. And then by MRI, I can do what's called the adenosine perfusion test. If this aneurysm is actually affecting the myocardium, if there is any perfusion defect in the myocardium, and that's definitely game changing for us, like regarding the management plan and regarding everything else going on with the patient. And definitely with the 3D, I can show the whole lesion for the patient as well as for the surgeon or the cath person if they like to stent those lesions or not. For pediatric hematology and oncology, again, according to the guidelines, American Society of Hematology guidelines for sickle cell and other anemias, iron overload can be calculated. It can tell you if there is any cardiac involvement. So whenever we see a cardiomyopathy for a patient which have a repeated blood transfusion, we know this patient have a chelating agent. Why the cardiomyopathy is happening? It's happening because of the hypoxia, or it's happening because the iron deposition. I can get the answer by a cardiac MRI. I can tell you exactly how much iron in the myocardium of the kid, and if we need to increase the chelation dose and stuff like that. Pediatric hematology and oncology, cardiac MRI evaluation, especially for anthracycline among long-term survivors for childhood cancer. This is the standard of care now that a lot of patients which show some diastolic dysfunction or show systolic impairment that you can do a cardiac MRI. But also, cardiac MRI have more diagnostic capability that it can early diagnose changes even with normal ejection fraction for those kids. So usually the drop in the systolic function happened late. The diastolic impairment happened first, and then later on the systolic impairment happened second. So I can diagnose these lesions early, and there are studies showing that using of ACE or ARBs can even prevent the progression or even delay the progression for cardiomyopathy patient, for those patients from developing cardiomyopathy. And I'm showing here what I'm talking about, what's called the strain analysis. So I can, from a cardiac MRI, I can not only calculate the systolic function and diastolic function and the diastolic volumes, I can do a strain analysis for this kid, segment by segment, and I can tell this segment is impaired versus this segment is normal, which is, again, it's something which is really helpful for the treatment for those patients. Pediatric rheumatology and immunology, you can see here vasculitis. There are certain protocols for cardiac MRI. We are using how the tissue characterization of MRI is powerful. So we can use something called the STAIR. And using this, it can show if there is edema in the vessel wall, if there is a narrowing in the vessel wall. So we use different type of sequences, and which it can tell me, oh, there is fibrosis going on in the vessels, there is edema going on in the vessels, there is obliteration going on in the vessel. This most probably it is a vasculitis process. This is Takayasu patient, and it show how we can diagnose those patients with that. Then post-transplant patient, now cardiac CT is actually start to be in the latest guidelines. It can be as value as cardiac cath. It has the capability to show you vessel by vessel. It has the capability to show you the atheromatous plaque at each segment, and make the surgeon or the cath person decide what size of stent I will use, how long is the stent, and if this patient is actually candidate for surgery versus candidate for interventional cath. So you can see here, this is the right coronary artery. I can see all the way down here, which is definitely echo will not provide that. MRI is incapable to do this. CT is capable to do that. And now, actually, they start doing some of the studies, which is known for years and years to be done by the cath people, that it can be done now by CT, which is flow fraction for MRI by CT. So this is a new era that it can tell how much flow is going on through the coronaries, and during systole and diastole, what are the flow reserve for the coronaries whenever someone is active. So functional fraction, now it's done by certain software by CT. Pediatric neurology, cardiomyopathy associated with muscle dystrophies, and you can see now also in the guidelines that how much it can calculate late gadolinium enhancement in certain areas, fibrosis in certain areas, and edema in certain areas. And you can see here the lesions, which coincide with T1 telling me that fibrotic process is going on those patients. Now, also there is a rule for lymphatic abnormality. So they did this study. It started at CHOP, Children's Hospital of Philadelphia, and it showed that Fontan patients have they develop a lymphatic obstruction and lymphangiectasia because the thoracic duct end at the left innominate, an SVC. And since the pressure now for the venous system is really high, it is arterial pressure, the lymphatic cannot go against pressure. So because the lymphatic pressure is usually low. So they started to develop a scoring system for single ventricle patient, talking about we should assess the lymphatic abnormality associated with single ventricle patient, and we can tell the surgeon that this patient, whenever you operate, have a high risk for chylothorax or need a lymphatic intervention. Nowadays, there is a big program developed in CHOP and started developing other pediatric hospitals, lymphatic intervention. So some of the pediatric cardiac interventions now are moving towards the lymphatic intervention. And I was lucky, one of the interventionists in UT Southwest was interested. So we used to do one day cardiac intervention MRI guided. And he used to do single ventricle patient. He used to do a lymphatic intervention. And now there are a scoring system. It's called the Dory classification. If you see any single ventricle cardiac MRI notes, you will find that I start adding, or I'm putting this lymphatic assessment. We do a specific sequence for MRI it's called the T2 weighted MRI. And the reason for that is to show the lymphatic of the chest and abdomen. And again, now it is a big era. We have Dr. Gay, I think, has a patient have a lymphatic abnormality, being referred to CHOP to do some intervention. So a lymphatic abnormality now is well-known finding for all those single ventricle patients. So I'm just sharing with you what are the orders. Cardiac MRI for morphology and function, cardiac MRA, cardiac flow quantification. Now, as I mentioned, we add in the EPIC system stress cardiac MRI for morphology and function, and we do congenital cardiac CT. So those are the main pediatric cardiac orders. That's my amazing team for MRI. I just ask them, please give me a picture so I can share it with them. So without them, as well as the cardiac and the CT team, I would be unable to progress. And they are an amazing team. I really appreciate their help. Also, sometimes we have some argument and a meeting, a lot of meeting, but they were really helpful. They really support me, and amazing team, and I really blessed by being with them. So I have 3 questions according to the CME. I have to put some questions. So I will start first question. 12-year-old male admitted with fever, history of COVID, diarrhea, injected conjunctiva. CRP was 7 milligram per deciliter with neutrophilia, hypoalbuminemia. Echo showed normal systolic function. Troponin 3000. What will be your next order?
Refer to cardiology.
So I will repeat the echo in 3 days. I'll do cardiac CT. I will do cardiac MRI without the contrast, or I'll do cardiac MRI with the contrast. So I'll go for cardiac MRI with the contrast. And the reason for that is we like to do the tissue characterization. So to do tissue characterization, I need to do the contrast to show up what we are looking for. This is an interesting case. A 14-month-old toddler admitted to hospital following a respiratory arrest at home after eating a piece of sausage, appeared shocked with a sudden respiratory distress. Mother gave a back slap while waiting in the ambulance following resuscitation. The child underwent emergency rigid bronchoscopy for suspected inhaled foreign body. No foreign body was found, but it showed, which revealed a segment of tracheomalacia involving the distal trachea with a normal upper trachea, carina, and main bronchi. Review of medical history revealed noisy breathing from birth, which was described as inspiratory and expiratory in nature, associated with intercostal recession. A diagnosis of laryngomalacia was made at 1 stage. The infant had been admitted on 2 occasions with bronchiolitis, requiring continuous positive airway pressure respiratory support. What would be your next order? Cardiac CT. We're talking about a vascular ring. So patients will not come to you telling you, hey, this is my diagnosis. We'll find something else. We'll find something else is going on. And it will be distracting. That's your capability as a history. Whenever you take a history and whenever you do the imaging, or what image you like to do, prioritize your resources. Then third patient, a 12-year-old girl admitted to the hospital due to 3 months complaint of generalized myalgia, arthralgia, left shoulder and elbow, and numbness and tingling in her left arm. I'm just to get this table so it collect everything so the slide will not be big. Severe pain in the left shoulder and elbow with numbness and tingling in the left arm. You know, that's if you tell to any adult ED doctor or adult doctor, he will tell you this patient have a heart attack. Especially if we get some troponin rise. Dyspnea, pallor, constitutional symptom, intermittent epigastric abdominal pain, associated with vomiting, diarrhea, headache, and epistaxis. So everything. And then signs, lymphadenopathy, pulsiness with unobtainable blood pressure in the left arm. Blood pressure was 130 and 100/70 and 140/90 in the right arm and lower limbs, respectively. Bruit over the left supra and subclavian areas. Hemoglobin was 10. ESR 113. Platelets 731. CRP is 35.5. So we are dealing here with a vasculitis. Okay. We can see that if there is pulsiness in the left side, means that the left subclavian artery could be involved. So what is the test which have a highest diagnostic resolution, which can show us the branches clearly? The cardiac CT. So cardiac CT will be the best choice for us. Although I'm expecting there will be a renal ultrasound down the line. Echo is not indicated unless I have certain things. I heard a murmur or something is going on. Upper extremity Doppler definitely will be something can be done later on. But if I have a need to diagnose this patient is something rare, but I was fortunate, I saw a couple of patients. It is Takayasu vasculitis. And also they have known to have something called the carotidemia, which is like if you try to touch the carotids, it is usually tender. And that's it. That's all that I have. Thank you. Any questions? Yes. Okay. Okay.
So back in the dark ages when I was in residency, our hospital did not like to look at radiology studies from outside hospitals. We wanted to repeat everything at our hospital. Mm-hmm. So in terms of thinking about utilization management, I was wondering whether currently it doesn't really matter what hospital the child's imaging was done at, or at this time, whether it still matters?
It can go both ways. From my side, if I don't see the images, it's very difficult to say how clear it is, and also who is reading. Like if this is coming from big center, definitely, and definitely it will be valid. I don't need to do the study. But on the other way is when I do when we do the study, we have the capability to share everything with UVA, and we discuss this in the surgical meeting with UVA, and they don't repeat our studies because they see our studies is valid. So they do decisions for surgery. We have this vascular vein case. We have a coarctation patient. We have a lot of coronary anomalies. We have I think a patient with a thrombus have endocarditis on top of VSD. So all these cases which we share with UVA, which is our main referral for surgery, they validate our images. On the other way, like if I get a report, it's very difficult to know unless I see the images. So if the images is diagnostic quality, but if it's study coming up from CHOP or Boston or big centers, definitely, and being read by pediatric cardiologists, definitely. It doesn't need to be.
There's still some bias that exists.
Yeah, exactly.
Related to what is the institution that's originating the study.
Yeah.
Okay.
But it's better than I thought,
Okay.
because that comes up, like if I have a patient and he can do the study, but I know it's going to need surgery, then UVA needs to be happy. And the couple of times I've called them, they said, fine, go ahead and do it here, and not blink at that. So I was happy.
And actually, the intervention, the head of the intervention, Dr. Henstock, shared with me maybe 2 weeks ago that in Intertology fellow we do cardiac MRI and we do CT for pulmonary valve replacement. So they do a cath-based pulmonary valve replacement. So there are certain protocols. So he shared it with me and said, like, you guys can do all your studies here. So we can do all pulmonary valve replacement studies here. And we will, we don't need to do it there at UVA. So we are good.
So time to acquire the images, how do they differ between MRI and CT? When I'm thinking about a child who needs sedation, who has, say, airway problems.
So for MRI, it is at least 1 hour. CT acquisition time, we're talking about second, 2 seconds, 3 seconds, we're done. I used to be, most of cardiac CT doesn't need a sedation. Unfortunately, we have some obstacles in some patients who have like developmentally delayed or have like any previous trauma that make them unable to even stand for this 2 seconds, or even once they step inside the CT and find people are just around, they freak out. We have been trying to use all our resources. I would reach to the intensivist, asking them for help to be able to help us for sedation. The anesthesia team is also really helpful. We're trying to use all the resources for the CT if we need those seconds for sedation. So we will not need in any of the CT more than 10 minutes. Going for the MRI, this is longer. But the MRI have already established anesthesia day, and which is usually Tuesday and Thursday, and they are there available doing other than cardiac. So, Dr. Gay.
I guess along those lines, for years, UVA, and I've asked you this before, I think you answered it, but I've gotten old enough, I can't remember. They always say, oh, we're going to do this, we're going to do a flash CT. Mm-hmm. I mean, in the younger people, because it's so much faster, that's always the answer. But the last time I said, well, what is a flash CT scan? And the cardiologist had no idea what it was. They just said, we'll do a flash CT. So Do you mind telling me what a
From the
flash?
technical, those are
That's
the
these guys.
special.
I've been looking at the pictures. We didn't start with flash, but we've evolved.
What does flash mean?
It's allowing us to take a really fast picture of the child at, basically a snapshot. You're doing large, so the CT that we're using is a large field of view. So you can almost view the whole heart, snap, snap, snap.
Got to do multiple.
So when UVA says that, it's not that they have a machine that we do not have.
I don't know if they have the alpha,
No,
but I believe they're using it.
actually, our capability, our CT is the top-notch CT.
Yeah.
Even it is better, I'm telling you the truth, it is better than the CT which I used to.
So what they should have done is just
Southwest.
left out the flash. They should have just said CT, and that word is just confusing.
Yeah.
It is a technique. I
It
will
is
tell
the
you.
technique,
It's a traditional software, it's something that we had to train to
Okay.
do.
But we have a different modification.
Yeah.
Like say, the same way we do sequence for MRI. So whenever I ask the technician for MRI to do a study according the lesion, what questions I like to answer. So I put the sequence, the protocol for MRI, the same for CT. So let's say I like to calculate, I like to see emotion. So I will do retrospective, which I will show systole and diastole. If I like to do just a structure, I will do only the prospective. And the prospective can go only in systole, or it can go into diastole according to the heart rate. So this is something I share with the team as like what protocol do you like to do? And we use different things that make like the contrast.
So
we
for
have to mix.
vascular abnormalities outside the heart, that's going to work really well.
But it's also
When you don't need to know something about function or inflammation or something like that.
Exactly. Exactly.
Yeah, and I will add too, our capabilities are very high because Dr. Nagiub's at bedside. So he's adjusting things on the fly, contrast load, volumes, really through getting the parameters of that patient because he's there.
Yeah, I can see
It's very high level, and I think it's exceptional, because everyone's different a little bit.
So I'm wondering also about sedation, knowing, our anesthesia situation and stuff. It seems like, coordinating that, getting them involved and happy would be a challenge.
Dr. Nagiub has had the pleasure of bringing 3 departments. You had between working with Dan Crowley, Neil McDonald, and myself trying to get.
Neil McDonald's an anesthesia guy, right?
He is. Because we don't have
I've heard he's a
our
good guy.
and anesthesia right now is very tight. Of course, obviously that's a big problem. But
Like if you have a 6-month-old with a vascular ring, I guess that requires some kind of sedation, doesn't it? Or can you really just do that so quickly you don't need anything?
I believe less than 1 year, you can get a good study because we're talking about seconds.
And it gets to be technique, where you do after breastfeeding, where you do a little sucrose. It gets to be a skill. They'll get.
Like the mother can't actively be feeding a baby to keep them quiet when you're doing the
What we
study.
usually
can they?
do, 6 months is a little bit like older, but if like we're talking about a couple of months or less, swaddle and feed and swaddle is actually, it's a known technique for sedation for pediatric cardiac CT. So what we do is just we feed the baby and swaddle the baby, put it in the machine, seconds, study is done. And it's a known thing. The problem
Do you
is
put them in anything? Like when we used to do calves many years ago, we had a technique for putting some supports and weighted things around the baby with a small amount of sedation, at least for a period of time, they would be perfectly still almost every time.
Different questions, but I think we probably need to close the channels now. So, but thank you very much.
Thank you.
You've interrupted my